Good evening. I'm Dr. Habibur Rahman, working as Professor of Cardiology. I'm basically interventional cardiologist. Uh, as in our clinical practice, we encounter lots of peripheral arterial disease patient. That's why among interventional cardiology, we also assigned to do some peripheral interventions. So today, my topic is critical limb ischemia, the way to treat by cardiologists. So let's start with the first case. 70 years old man presented with history of intermittent claudication, more on the left leg than right. He was smoker, hypertensive, and diabetic. Duplex scanning revealed anterior tibial artery, posterior tibial artery, and peroneal artery have stenosis, high-grade stenosis. His coronary angiogram revealed double vessel disease. And case 2, 63 years old, retired diabetic, hypertensive, and post-PCI 3 years back in LADL, CX, and RCA. Patient now presented with history of partial amputation of the fifth toe, left fifth toe, and he was waiting for below-knee amputation by surgeon. He missed follow-up for a couple of years. PCI was done by me as well. And his peripheral angiogram shows inflow lesion in the lower SFA as well as diffuse lesion in the BTK vessels. And another case, 78 years old male, diabetic, hypertensive, ex-tobacco chewer, presented with non-healing left foot ulcer. So with these scenarios, we have to think, what is the diagnosis of all these cases? How to assess the severity of the lesions or the condition? What are the treatment goals? How to manage and optimize our treatment strategy? Obviously, these are the case of critical limb ischemia, that is CLI. What is it? According to the Inter-Society Consensus for Management of Peripheral Arterial Disease, that is TUSC 2, CLI is defined by the presence of chronic ischemic rest pain, ulceration or gangrene, attributable to arterial occlusive disease, supported by objective findings in case of ischemic rest pain with ankle pressure less than 50 or toe pressure less than 30, and in patients affected by foot ulcers or gangrene by an ankle pressure less than 70 and toe systolic pressure less than 50 or TCPO2 less than 30. So, however, chronic limb threatening ischemia is more appropriate term for these conditions nowadays. Why to be treated critical limb ischemia? Because patient outcomes in critical limb ischemia are largely determined by morbidity and mortality caused by cardiovascular events and functional impairment caused by limb loss, that is amputation. Although over the whole spectrum of peripheral arterial disease, cardiovascular events such as myocardial infarction and stroke occur in 30 to 50% of subjects over 5-year period, patients with critical limb ischemia face these over a 1-year period an outcome worse than many cancers or severe heart failure. In USA, one study, they showed the mortality is much higher even just after lung cancer. Similarly, although the risk of major amputation at or above the ankle is less than 5% in the following 5 years in the patient with intermittent claudication, it is at least 30 to 50% in the first year in patients with critical limb ischemia who do not have revascularization yet. So, how to assess the severity? It is clinically assessed by Rutherford and Fontaine classification. In Rutherford classification 0 to 6 and Fontaine classification it is up to 5. But the critical limb ischemia in Rutherford classification 4 to 6 and in Fontaine classification 3 to 5. So how to investigate? If we find such cases, we have to investigate. We have to see the full blood count, any marker of inflammation, coagulation profile, diabetic status, fasting blood sugar, and lactate to see the metabolic state, septic workup may be needed, blood cultures, wound swab, and culture and sensitivity. And we can investigate by non-invasively as well as invasively. By non-invasive investigation, that is cheaper, duplex ultrasound. By this duplex ultrasound, we can label the lesion, severity of the lesion, and significance of the lesion. And also by CT angiogram and MR angiogram, though they have some limitations for both. And during intervention, that is arteriography or angiography directly. 3 pillars of management here is medical, interventional, and surveillance. So in medical, the prime treatment is control of pain, reduction of major adverse cardiovascular events, and also managing the risk factor, and thereby improving the quality of life. In interventional management, goal is to include revascularization to achieve the limb salvage, wound care to achieve the healing, and orthotics or offloading in order to achieve the maintenance of ambulatory status. And need surveillance, good surveillance. Goals to include close follow-up and monitoring after treatment delivery, even after healing. The first sign of stall progress is clinical decline or recurrence should prompt an immediate referral to the critical limb ischemia team. Unfortunately, we do not have critical limb ischemia team in all the institutes. We need it. So let's come to our first case, that is BTK lesions, diffuse lesions, both in anterior tibial, posterior tibial, and peroneal. So we decided to do intervention. We started balloon dilatation of 3 vessels with coronary wire and coronary balloon, and succeeded, ultimately found good result, and patient got rid of severe symptoms. He was discharged. And case 2, we treated first the inflow, then outflow lesions by same coronary wire and balloon, and ultimately ulcer healed. Patient were discharged. And in case 3, also treated the short CTO and BTK vessels by ballooning, simply ballooning. And patient discharged home. So take-home message, for the treatment of critical limb ischemia, patient needs comprehensive team approach by cardiologist, vascular surgeon, orthotics, podiatrics, and endocrinologist. Revascularization in proper stage is the prime way to salvage and prevent the amputation, salvage the lesion and prevent amputation. Restore at least one straight line of blood flow to ischemic foot and maintain its patency as long as possible, or at least allow ulcer healing, pain relief, avoid recurrence of CLI. Due to evolution of technique and availability of dedicated devices, the endovascular fast to be the preferred approach in treating BTK lesions causing critical limb ischemia. Thank you.